Hello there, everyone. It's wonderful to be here for another CE Wire. Thank you so much for the kind invitation. I wanted to bring you something fun and playful today as we journey through some deep, dark science and some very light-based science. Please pardon the pun. But what I want to talk about today is the scientific evidence supporting IPL, but I decided to take a Star Wars theme with this fun content. So I hope you'll sit back, relax, and enjoy the playful approach. My name is Laura Periman, and I live in Seattle, Washington. I'm the Director of DryEye Services and Clinical Research at Evergreen Eye Center. I wanted to share my financial disclosures with you. And here's the roadmap. Here's the galaxy map we're going to go over today. I want to talk about the MGD and chronic dry disease pathophysiology, the disturbance in the force, and there'll be a lot of other lectures focusing on this. So I'm going to skim across the top and give you my dorky immunomolecular biologist viewpoint on the topic. Then I want to talk about how dry disease and MGD is a galaxy-wide problem. And what I mean by that is there's far-reaching implications for the individual affected, the biopsychosocial considerations. It's a local regional disease, and there's considerations that we have to take into account. But I also want to talk about the systemic considerations, the comorbidities, and explore this gut microbiome galaxy, this galaxy of bacteria that we have living within us, hitching a free ride. Then we're going to go into intense pulse light as the MGD BESTO lightsaber, and I'll explain later what the BESTO algorithm is. And finally, I'd like to share a little bit about our galactic voyage and what we've learned along the way. And there's a gallery of cases in that section as well. And I'll be done in about 50 minutes. I forgot to set my timer to make sure that I am finishing on time. Here we go. So, disturbance in the force. MGD and chronic dry disease pathophys. We'll quickly touch on inflammation. I'll explain a little bit about the innate and adaptive immunity, and then this brilliant concept for uniting aqueous and evaporative dry disease in the double vicious circle paradigm. So you're going to see this definition a ton during this weekend, and it's worth going over. And I've highlighted the parts that I think are particularly relevant. It's loss of homeostasis. There is hyperosmolarity. That means the salt load is too high in the tears. There's definitely ocular surface inflammation, and there's some really fun cellular biology going on there. And then finally, there's this neurosensory abnormality component that we now have unique methods to directly address. So let's go over this a little bit. The lacrimal functional unit, it starts in the front of the eye where the corneal nociceptors are. We have osmoreceptors, we have thermoreceptors, we have mechanoreceptors, and we have inflammation-inducible nociceptors as well. Those get turned up and upregulated in the context of chronic inflammation, which helps to explain why some of our patients have a significant pain component to their dry eye. At least that's where the forefront of the pain story is. This isn't a chronic corneal neuropathic pain lecture. That one will have to wait for another day. But once the surface senses that there's a problem in the home front, the signal then goes back to the brain, is integrated in the brainstem, then it goes there via the trigeminal nerve. The command signal is sent to the salivary nucleus, and the command fibers go to the lacrimal gland, the goblet cells, and the meibomian glands. Now that's kind of a new concept, that your goblet cells and your meibomian glands are neurobiologically connected to your central nervous system and are under the command of your central nervous system. But we know this is true, and it's absolutely amazing, and we can take advantage of it as clinicians in our integrated approach to providing dry eye relief. Here's an example of neural stimulation currently available as TrueTear. This patient's osmolarity was very high before TrueTear, and just in an in-office demonstration, we rechecked the TrueTear afterward, and it was a nice physiologic level of 285. So you get this integrated stimulation of the entire lacrimal functional unit. I'll also be going over later some of our personal data regarding osmolarity and IPL therapy, which is the main theme of the talk. Neurostimulation for the lacrimal function unit comes currently as an FDA-approved form as an electrical stimulation in the form of TrueTear. You've all seen this. Goes up your nose, stimulates your nasociliary lymph that runs along your nasal septum and sends a feedback loop to trigger the letdown of a physiologically complete tear. And I liken it to breastfeeding an infant. When the infant latches on, there's a stimulus and a neural reflex to the brain, and then there's the letdown of milk. And it's not unpleasant. It's a very similar process that we're able to take advantage of. There's also a chemical intranasal approach that's in phase 2 development. That's with Oyster Bay, and they're using a nicotinic acetylcholine receptor agonist, and that's showing some excellent data. So an alternative approach. And then there's also an extranasal vibration approach that is in early clinical development as well. So look for more things. And we're not the only ones to deal with a dry problem using electrical stimulation. Our ENT and oromaxillofacial colleagues are using a device like this to stimulate mandibular and salivary gland production for patients who have Sjogren's disease, who have had radiation therapy to the head and neck for cancer, etc. This small series showed excellent results. I want to point out one thing though. The authors posited that the stimulation may lead to salivary gland regeneration, which is interesting that they made that statement because what they were basing it on was just improved salivary output. So as we know in eye care, the lacrimal gland does not regenerate, and we don't think that we can get it back, but we can certainly stimulate what remains. And one of the other reasons why they posited that is that in animal models, electrical stimulation of the parasympathetic innervation increases salivary gland mitotic activity. So there's some more information going on there, some more science going on there, and I want us to continue hunting for what the story is on the lacrimal functional unit and neural stimulation. So we've been talking a little bit about outer space, but I want to talk about what's happening on Earth. This is my grandfather's horse Rocket, and he's shoeing this horse, and he always used to say you can't ride a three-legged horse, and that's what you did on Earth, but we're not in a spaceship at the moment. I want to talk about the 4 steps to the DEUCE-2 diagnostic algorithm. You've all seen that. There's a lot going on there, but really it just comes down to 4 steps, just 4 legs on the horse. It's pretty easy. Ask the questions, assess the risk factors, do your diagnostics, classify and treat. Pretty easy, a lot less overwhelming. MGD is the lion's share of the diagnosis and treatment, but I don't separate it out. I keep everything as part of an integrated plan, and I'll explain why later. The TFOS DEUCE-2 report goes on to talk about interventions. So a level 2 intervention includes things like preservative-free tears and IPL therapy. It's actually a level 2 recommended intervention. So the knowledge, the acceptance is gaining traction, and this report is 150 worldwide experts that came up with this treatment recommendation list. And of course, I back that up. My foundational approach is still your omegas. I still believe in omegas and an immunomodulator, and then I'll layer on these other therapies. However, disclosure, I don't like to do punctal occlusion at all if I can avoid it, but that's another talk. So back on Tatooine, what's inflammation got to do with all this goings on? Well, back to the pathophysiology report, there's loss of homeostasis. That's part of the definition, right? There's a stress response immunologically that leads to amplification of that response, and then the damage phase, and it's chronic self-perpetuating double vicious cycle. We have scientific evidence demonstrating improvements using IPL in part of this cytokine amplification cascade. We know it helps MGD, so there's role for it in evaporation. Patients report lower speeds, the scientific literature shows lower speed scores. Patients report improved photophobia with a series of treatments, less foreign body sensation, and also improved tear film stability, improved tear breakup times. So when we're talking about what's going on the immunopathophysiologic level, there's a couple things I want to just lay some groundwork on, and that's the difference between innate immunity and adaptive immunity. Innate immunity is the system that's always there. It's like the guard dog in the fence. It's always there, ready to respond in kind of a non-specific way to threats. Adaptive immunity is the smart adaptive response. That's when you put up things like your Ring camera and all of these other memory and technology assisting strategies to be more precise in your reaction. Now, the problem with dry eye disease is that it's an aberrant activation and loss of homeostasis and loss of immunoregulation, and it pushes everything over to adaptive immunity. It is a hijacking of your normal biologic, immunologic defense system. The problem with that is then it becomes this chronic damage and self-perpetuation cycle, and that's why we have to intervene with all of the modalities that we have. Looking at it a different way, this system is designed to protect you. If there's bacteria, fungus, virus, foreign body, a scratch, trauma, whatever it is designed to respond. That's here. Initiate inflammation, call for help, amplification, get the precise helpers to the scene, and then finally, with immunoregulation and homeostasis, with immunoregulation in place, we can return to homeostasis. That's what's supposed to happen. With dry eye disease, that return to homeostasis is offline, and you end up with this chronic dry disease vicious circle. Looking at another way, there's initiation of the inflammation, amplification, recruitment, and damage. And what you see in green is where we know steroids act. Where you see hot pink is where cyclosporin acts, and where you see purple is where lifitegrast works. And here is where the peer-reviewed literature tells us that IPL works. Pretty cool. So it's just a roadmap of it. I don't want you to get bogged down in the details. It's just a visual roadmap of where we know this works to date. This may be familiar to some of you. This is adapted from Victor Perez's paper 3 years ago. And this is just a deeper dive detail into that initiation, recruitment, or amplification, recruitment, and damage phase. And again, here's where IPL works. So there's a role for your immunomodulators, for IPL. All of these things team up to get control of this runaway immunologic freight train. Oh, the double vicious circle. I love this concept because it doesn't separate out aqueous deficiency and evaporative dry eye. You don't need to do that anymore because the fact of the matter is one begets the other, and almost everyone is a hybrid state. So I focus on what's really underlying all of this, and that's inflammation, right? And then target other expressions of that ocular surface that you see. Moving on to a different topic, the galaxy-wide problem. This is what dry disease means for the patient, how it affects their life. There's biopsychosocial considerations, local regional immunologic considerations, and then finally, I think we need to think bigger and systemically. We are clinicians. Our job is to promote health, and I'll give you some tools and things to look for. So the disease burden, there's an aesthetic aspect to dry eye and comorbidities like rosacea, functional, productive, quality of life impacting aspects. There's a high level of neuropsychologic compromise. The happiness study out of Japan showed that the happier the self-reported happiness score, the higher it was, the lower the perception of dry eye disease discomfort, irrespective of the signs. So mindset is important. You need to encourage and cheerlead, and there's some actual neuropsychological reasons for it. Financial, it's expensive to treat dry eye disease for the patient. And that can become a frustration. It takes a lot of time. The outcomes can be impacted surgically, as you know, and contact lens dropout, all of these other things. And then finally, nobody really wants red eyes. So what are the economics of this thing? Everybody agrees that cancer is a big deal and it's expensive, right? So if you look at direct costs of cancer treatment, it's about 80 billion. But 55 billion total societal costs are due to dry eye disease. Oh my stars, that's significant, especially when you put it in context of $15 billion in surgical and non-surgical cosmetic procedures in the year. And finally, our health insurance payers like to complain about their role in all this, but look at the tiny drop in the bucket they are compared to the total burden of dry eye disease in the red sphere. So I don't feel so sorry for them. They need to step up, in my opinion. The economics of MGD. Well, a low estimate, but 33 million Americans are estimated to have dry eye. And if you accept that 86% have a component of MGD, that is significant. Only about 2 to 3 million are being treated. And here's what's really interesting is cataract surgery gets so much attention, but look at what a tiny piece of the pie it is. There's only 4 million cataract cases done in the US every year. Glaucoma is about 2 million and diabetic retinopathy is about 1.5 million, and these circles are drawn to scale. What about the time, the financial, and the lifestyle aspects for patients? Patients have to